On a Tuesday morning, she stops halfway to the door and takes one deeper breath. The murmur was in the recording. A standard exam missed it, but the model flagged hidden valve disease. That is the anomaly. The body can change before symptoms, and software can hear it first. Chronic disease causes about 71% of deaths worldwide. For one patient, that does not mean a dramatic collapse. It means a missed window. The difference between a cheap follow-up and a late, expensive rescue can be months, sometimes years. AI is now being trained on X-rays, CT scans, cough audio, heart sounds, EHRs, wearables, and genetics. It is not guessing in the abstract. It is searching for weak signals that human eyes and ears cannot hold together at once. The real question is simple. Can those weak signals become early action before disease becomes obvious? Disease does not appear all at once. What else can AI detect before you feel anything? A tumor changes tissue texture before pain. Tuberculosis changes the acoustic shape of a cough. Heart valve disease changes blood turbulence, which changes heart sounds. But here is the surprising part. Cardiovascular risk also leaves fingerprints in labs, rhythms, history, and imaging. A clinician can read one chart. A model can compare millions of tiny features across many charts. That matters because the signal is often too faint, too distributed, or too early for routine care. This is why AI can detect early breast cancer, tuberculosis, and COVID-19 from X-rays and CT scans that look ordinary to human readers. It is also why cough analysis has reached 86% accuracy for TB screening, and why AI-enhanced ECGs have shown 79% sensitivity and 79.5% specificity for atrial fibrillation. The model is not understanding disease the way a doctor does. It is fitting a high-dimensional map from input data to risk. In one cardiovascular study, a deep neural network reached an AUC of 0.91 with 88.5% sensitivity and 85.2% specificity. Framingham was 0.76. ASCVD was 0.74. Translated, the machine separated higher-risk people from lower-risk people better than the standard scores medicine has trusted for years. Another system found 94.1% of undiagnosed valvular heart disease cases from digital stethoscope recordings, while primary care professionals using traditional stethoscopes found 41.2%. That is not a small edge. That is a different frontier of detection. AI-driven predictive analytics has also been reported to improve early detection rates by up to 87% in cancer and cardiovascular disease. And it is not limited to one organ. AbleDex uses conditional variational autoencoders to learn from TIR-EV proteomics for early non-invasive detection of neurodegenerative and ocular disease. AI-estimated biological age from chest X-rays can also act as a marker of decline and mortality risk. The machine is not reading destiny. It is reading deviation. But here is the part that changes the math. When the signal is strong, AI can outperform the baseline. In preventive cardiology, a DNN has reached AUC of 0.91 against 0.76 for Framingham and 0.74 for ASCVD. In one heart attack or stroke study, AI predicted risk correctly in 74.5% of cases versus 72.8% for the standard method. That sounds modest until you remember what it means in a clinic. Fewer people slipping through because their chart looked normal enough. The impossible part is this. The model can identify danger in people who look healthy enough to send home. But early screening lives inside a population problem. Imagine 1,000 apparently healthy people. If disease is rare, even a strong model will flag many more people than it finally diagnoses. That creates follow-up scans, extra visits, anxiety, and clinician overload. And the better we get at listening for whispers, the more often we will hear echoes. Positive predictive value is the real bottleneck. When disease is uncommon, many alerts do not become diagnoses. Add the infrastructure problem. Fragmented records, wearables, imaging pipelines, and secure data sharing are uneven across clinics. Then there is the moral failure mode. If training data underrepresent women, Black patients, and Latinx patients, the model can inherit the blind spots of the system that produced it. People without wearables, regular primary care, quality imaging, or digitized records may never generate the data the machine needs. That is not just bad prediction, it is unequal invisibility. So what is the real value? Not miracle diagnosis. Time for confirmatory imaging. Time for treatment when disease is still cheap, manageable, and often silent. Preventive interventions can cost up to 10 times less than treating advanced disease. And in the Anchor case, the warning was not doom. It was previously undiagnosed valvular heart disease and cardiovascular risk that ordinary primary care had missed. The point was not to replace the clinician. It was to surface the right patient sooner. Over the next 5 to 15 years, the target is not one omniscient model. Instead, it is a validated screening stack that combines imaging, labs, rhythms, cough, and history into one triage layer. That stack has to prove itself in diverse, real-world populations, not just in clean, retrospective datasets. If it works, it could compress years of diagnostic delay into a routine alert. She ties the shoes, walks out, and still feels mostly fine. That is exactly why the warning matters. If this technology existed today, would you want it watching for disease before symptoms? The constraint is real. The data exists. Whether the systems built around it can act on it at scale, that is the next engineering problem.